So our recording has started. So for those of you who are joining this meeting, please know that it will be recorded in case you have community partners and other coworkers who wanted to join us today and aren't available. I'm also going to go ahead and ensure we have our closed captioning ready to go. So if Jessica, you just want to do a thumbs up if you see that. Oh, perfect. You read my mind. All right. Well, it looks like most of you are on mute, and that is correct. So if you could just keep yourself on mute, and that will just help sort of minimize distractions in case you have background noise. And I'm going to have Karina and Jessica on the chat box in case you want to just let us know if you want to unmute yourself or if you need us to unmute you, if you have anything you want to share, any ideas or input. And just so you're aware, most of us will keep our cameras off. If you'd like to keep your camera on, that's perfectly fine, but most of us will have the camera off until we're speaking, really just to minimize distractions. But again, if you'd like to keep your camera on, that's fine. I'd love to see people's faces. It just makes it way more human. I miss seeing people in person, and I know this is a different world we're all getting comfortable with, but hopefully not too comfortable, right? So for those of you who don't know me, I'm Ruby Graven, and I'm one of the many regional outreach coordinators with the OHA Community Partner Outreach Program. I've been a part of the team for a number of years now, supporting the community partners who walk clients through the Oregon Health Plan application. And prior to that, I was a community partner myself. So that's a little bit of background. I also spent some time working in a family planning clinic directly with clients, and I speak Spanish. Both of my parents were migrant farm workers and were born in Mexico. So it's been a really good opportunity to learn from those real life experiences and have that opportunity to partner up with all the community partners in my region. And so what I'm going to go ahead and do is turn it over to Karina so she can introduce herself and tell you a little bit about her background.
Hello everyone, my name is Karina Reardon. I'm a regional outreach coordinator with the Community Partner Outreach Program, and the region that I serve is the Coast. And
Thank you, Karina.
Pass it next to Jessica.
Hello everyone, my name is Jessica Diaz. I was a regional outreach coordinator. Now I'm the provider outreach and engagement coordinator on the team serving the whole state.
Thank you so much, Jessica. All right. So for those of you who are on the call today, it would be fantastic to get an idea of which counties you work with or which communities you work with. So if you have a moment, feel free to just add in the chat box and let us know which communities you're representing today. Okay, so just a few housekeeping items. If you aren't receiving emails about our Medicaid waiver and you want to get those directly in your inbox rather than from a coworker or colleague, feel free to email our community outreach box. And again, just remember this meeting is recorded. So if you have team members who weren't available today, they can walk through this entire conversation on their own time when it's most convenient for them. We also have a Spanish interpreter today. If anybody prefers to receive this conversation and be a part of this conversation to give input in Spanish, this opportunity, thankfully, we do have it available to you today. So just be sure to click on that little globe, that little picture there. It looks exactly like a little planet, in order to switch over to the Spanish channel. Another housekeeping item is that icons here that you can see in front of you should remind you to either have a conversation via the chat box. So you'll notice these little pictures at the bottom. We have the chat box, we have the 3 people having a conversation, and then we have sort of like a picture of maybe like a compass. But what it just means is we're going to run a poll. We're going to ask you to give us your response. And so these icons are really here for us as presenters so we can just remember to run the polls and ask the questions. And also as a reminder for community partners who might have a few things going on to say, hey, we're having a conversation here. Come back to our meeting. I know sometimes people are multitasking. But thank you so much for your patience today, waiting for community partners to log in. And thank you for your time. I know a lot of you have a lot going on. Okay, so just bear with me as I move. Some of these slides are playing little games with me. Okay. I may actually need to look at different slides, a different screen, only because it looks like my Zoom is sort of blocking everything. So for those of you who didn't have an opportunity to participate in the waiver meeting last time, I wanted to just check in with you. I know Karina and Jessica had mentioned the fact that there are still community partners who are learning about the waiver. I know some of our Spanish speaking presenters reminded me that, hey, you know, Ruby, there might still be people who don't know what a Medicaid waiver is. You know, we're constantly talking about this 1115 waiver, this Medicaid waiver, and what do we really mean? So I wanted to check in with you and ask you if you are familiar with Oregon's Medicaid waiver. And I'm going to go ahead and run a poll, ask you the question. So you should be able to see this poll here in just a moment. And Jessica, I'm just going to check in with you via text. Wonderful. So it looks like the poll is up and everyone can see it. We're curious. We've been talking a little bit about the poll for the last, or excuse me, the Medicaid waiver for the last few months. How many of you feel comfortable with the information? How many of you feel like, yeah, I know what this is? And how many of you feel like, I'm still learning, I'm not quite there yet? And there is no right or wrong answer. So please do get comfortable with being 100% direct with us. This is exactly what partnering is all about. So 77% of you have voted. All right, we're getting pretty close. Again, how many of you know what we're talking about when we refer to Oregon's Medicaid waiver? Okay, so I'm going to go ahead and end our poll. And you should be able to see that most of you are still learning about Oregon's Medicaid waiver. And so we have a few community partners are saying, actually, I'm just now hearing about this. So we know that a lot of you have been really busy with COVID response and making sure communities have access to community resources. A lot of our communities are, quite frankly, in survival mode. So if you're still learning, that's perfectly understandable. I'm still learning too. Okay, so for those of you who are still learning about the Medicaid waiver, essentially there are these federal rules that set minimum standards related to eligibility and required benefits. But Oregon can ask to waive some federal rules to have more flexibility and offer the Oregon Health Plan to more people and cover more services than usually allowed. So what's really exciting about communities being involved in the Medicaid waiver is that you're now informing us and you're leading the way. And this is truly becoming a community-driven effort. So every 5 years, Oregon will renew its agreement with the federal government around the Oregon Health Plan. And so what this means is that you as communities can propose new changes and really guide us in how we run our program. And then at that point, what we do is we take what we're hearing from community and we submit this to the federal government to hopefully accept our application. There might be proposals or ideas that could be rejected. And many times our ideas don't necessarily result in funding. We're really looking at making sure we stay budget neutral. But with that said, most important piece is that as we're designing the Oregon Health Plan, we're doing this with community input at all angles, not only front and center and at the core, but coming from different angles. So thank you so much for those of you who were a part of the first meeting and have now joined us for the second meeting. If you couldn't be a part of the first meeting, know that that meeting was recorded and that we will continue to partner with you as our community partners to design Oregon's health plan. All right, so now that we've set the stage, for those of you who are thinking to themselves, I'm a little confused with the Medicaid waiver workshops and the community partner Medicaid waiver meeting series, but just know these are two different opportunities. The community partner Medicaid waiver meeting series, so you're in meeting 2 of 3 today, is really focused around you. It's focused with our community partners. This is really a dialogue with our community-based organizations, our faith organizations, our schools, all the different community partners we work with to ensure that our members have health coverage, that they have assistance with navigating their OHP. And the Medicaid waiver workshops have a lot of similar content, but they're really focused around other types of stakeholders like CCOs, hospital associations. So just know that there are 2 different opportunities. You're welcome to attend both. And these meetings are really going to be focused more around the community partner voice and what we've heard from you. So the waiver renewal is a recurring process. As I mentioned earlier, this is sort of a living, breathing process. We have a time frame to engage with our community partners and to partner with you. And then we move on through our timeline. So I'll be talking more about that. We will actually be talking about that together today. But what I want to do is just circle back on what we heard from you in May. So our first meeting with our community partners did take place in the month of May. And what we heard from you, and so for those of you who couldn't participate, is that you want coverage to be expanded to all people. There's a lot of eligibility rules and confusion about where different groups go and where families get broken up. And so what we heard from you loud and clear is expand coverage to all people, make sure more people are covered. Reduce barriers is basically what we heard. Offer more robust benefits. People need affordable and accessible healthcare. We want healthcare that is communicated in a way that people understand. So using more plain language when we're doing outreach to community partners and community members is very critical. It's very easy for us as state employees to sometimes get stuck in the health policy world and get really technical about the work we're trying to do. And really what we need to be doing is making sure we're talking about this work together as partners and that it's easily communicated, that it's simple, plain language. So this is something we heard loud and clear. We also understand that some of our outreach materials need to be available in video format. We know some of our communities prefer to have videos over written documents. And loud and clear, we know that our materials need to be available in different languages. We also hear that there's distrust and fear in communities. And so, you know, when we're talking about signing up for health coverage, we are aware that some communities are fearful of signing up for government programs. And, you know, some of those fears are related to immigration concerns or different things are hearing through word of mouth. We know that people want to know where to take problems that cannot be fixed through the Medicaid waiver. So after the waiver workshop, we did hear from some of the community partners who said, hey, you know, we have these concerns about the organ health plan and we're taking them to you, but it seems like some of the ideas or some of the different broken pieces we want to fix can't be resolved through the waiver. So where else do we go to make these improvements to the organ health plan? And so we will be talking about that today because we know it's important that we direct people in the right direction and that we aren't taking information to the wrong place, but rather having these conversations in different places and making sure that those different places are a good place to have a fruitful conversation and also take them, you know, to the right coalitions or committees and escalate anything we need to be having conversations about. So with that, in May, you asked some really important questions. And what these questions were related to is like, what are we going to do with the information that you're bringing to us? So we talked a bit about the policy concepts. We talked about how things need to change and what areas we need to improve. And you said, hey, these concepts are good, but how will you as the Organ Health Authority show us that these become the reality? And then you asked, how can we make sure our communities know that we as representatives in this meeting have been heard and acted on by the Organ Health Authority? And you wanted to know how you can continue to work and partner directly with the Organ Health Authority. So with that, I have some ideas and I want to know if these ideas work for you or if there's something different we should be doing. And I know Lori's on the call today, so there might be something she'd like to add. But I would say first, I would make sure you are visiting our Medicaid waiver website. We do have that available in English and Spanish. We have materials that you can share with communities available in multiple languages, something like over 10 languages, describing what the Medicaid waiver process is, what it looks like, and where communities can submit input. So it's very important that we hear from you. The policy concepts have been shared with you in multiple languages as well. Those are posted to the website. And we need to hear from community partners and from community members. I will tell you, I sent the policy concept papers out again this morning, and 30 of you had requested we get those policy concept papers out in different languages. At the very least, it was 30 of you. So I want to be sure that you read through those and that you take advantage of this time. Hopefully we hear back from you on these draft concepts at the very latest by next week. Remember, this is sort of a draft iteration, and so you will have more opportunities, but we want to hear from you. Okay, so I'm going to take a moment to see if Lori, do you have anything to add in how people can continue? What are ways people can continue to be heard, and what we plan to do to ensure that any of the ideas, needs, concerns are being escalated within OHA, the waiver work?
No, thanks, Ruby. I think you covered it pretty well. I guess I'll just add that for all the meetings that we have been, they're recorded and we capture all the ideas that are presented. And then if right now there's a summary of those ideas that was released to the Oregon Health Policy Board today. We'll continue to capture ideas as we go, but we are committed to documenting them and looking at all of the voices that contribute through these calls and webinars. So thank you.
And then Lori, will you actually share with the community partners the role of the Oregon Health Policy Board?
Sure. The Oregon Health Policy Board, it oversees the policy directions for the Oregon Health Authority. It's a community board. It meets monthly, and they provide oversight and direction on policy issues across the health authority. They also sponsor a number of subcommittees, including the Health Equity Committee of the Oregon Health Policy Board, and we're meeting with them on the waiver, I believe, Thursday this week.
Thank you, Lori.
Yeah, no problem.
Okay, so I'm going to look in the chat box and see if we have any other ideas or any requests on what we can do to be sure that we are hearing you and that we ensure your ideas become reality. And if I'm speaking slowly, I just want to make sure the interpreter is catching everything I'm saying. So if you're wondering why on earth is Ruby speaking slowly, I just want to be sure that our community partners who speak Spanish are catching this, and Mark is like, yes, thank you. Okay, so I don't see any other ideas in the chat box.
Ruby, we do have a raised hand though.
Okay.
So George.
All right. George, are you able to unmute yourself? There you go. Thank you.
The three concerns that I wanted to bring up was, I don't know if I have said this in the other meetings before, but has there been a consideration on raising the income limits for people to apply for OHA, OMEP? And second question would be, once this is all come into place, what part can the CAC play in this? Would they be responsible in the CCOs on how to help the community in this?
Yeah, so I think, so were you asking, I just want to make sure I caught the first question. Are you asking if we plan to change the income criteria for the Oregon Health Plan so that more people are eligible?
Yes.
Okay, that's what I thought. For a second there, I thought I heard you say OMAP, but I think that's something different. And so definitely those are strategies we're looking at, and we're going to be talking about that today. And I would say the question about the CCOs and how the CACs can be involved, Lori, I'd love to hear your thoughts on that. And then I have something to add in terms of what community partners can do in some of engaging some of their communities and making sure they're working with their CACs.
Sure, happy to answer. To the first question, we aren't looking at income limit increases at this point. We are looking at extending coverage, so possibly asking for children to have 5 years of coverage. So once they qualify for the Oregon Health Plan, they could stay on for 5 years. Similarly, families staying on if their kids are covered, and then 2-year adult continuous eligibility. So we're looking at ways to keep people on the Oregon Health Plan longer, and if they no longer qualify, easier ways for them to find insurance through the marketplace. For the CAC, or Community Advisory Councils, that are part of the CCOs, we are not making big changes. The role of the CACs is already in the waiver and then in contract, but they certainly can have an important role in a community voice and providing that community voice to the CCOs. Beyond that, we don't have specific plans for the community advisory councils, but we are considering, you know, how they will work with the proposed health equity zones. And so, Ruby, you said you had ideas around how community partners can engage as well.
Yeah, I'm just thinking about, so we haven't been able to have in-person community partner collaborative meetings since COVID. But I do remember our CCOs attending those community partner collaborative meetings, and they would bring flyers and different opportunities to reach out to community members to join the CAC, the community advisory committees. And I'm sorry if I said that wrong, but just know that those, what has been really helpful, and that's something community partners have shared, is making sure those recruitment opportunities are available in various languages. So if we're asking members to join or work with the CCO, making sure that materials are available in multiple languages.
Thanks. The one problem I'm really hearing from everybody is the toll-free number that OHA has. Once they dial that toll-free number, they either get disconnected or they're not even being helped with their problem on healthcare on OHA. That might have to be changed.
Okay, so when people call the 1-800-699 number 9075, I think there's a long wait time. Is that what you're talking about, George? It's just they have questions about their OHP, they want to report something, and they're just having to wait on hold for a while or a long time.
Yes, and once they get there, no one seems to know what they're even talking about in OHA. There needs to be more education and less wait time.
Yeah, I really appreciate you bringing that up. Karina and Jessica have been very involved in having conversations with our community partners and our call center to track those issues and call volumes. So what you're talking about very much aligns with what we've heard from community partners as well.
People are just frustrated, especially in Southern Oregon here.
Right, and with having limited minutes on mobile phones, it just makes it even more challenging. Absolutely. So Karina and Jessica, if you could just make sure to make note of that, and we can follow up with this group. And it looks like CJ, you have your hand raised too. CJ, did you have something to add? Okay. You're welcome to also add in the chat box. Oh, CJ, did you unmute yourself? Okay. All right, so I'm going to keep us moving along. I talked a little bit about the timeline, and the process we're in right now is really public engagement, is partnering up. We're partnering up with our community partners, with our CCOs, and we want to hear from you. We want to know, are we on track? with our Medicaid waiver work? Is there something missing? Is there something we should be doing differently? And more importantly, here's what we've heard so far. So we're still, as I mentioned, in this kind of orange circle summer timeframe. And what we have done is come to you to explain what we've heard from our COVID listening sessions, the input we got from CCO 2.0, the State Health Improvement Plan, and some of our community partner meetings. So there's a lot of different information coming from community partners, and the concepts have really been put together with your input. I know there's been concerns from community partners about, you know, where is this input coming from? Did it come from thin air? And absolutely not. We've been compiling this feedback for years, quite frankly, from CCO 2.0 and some of the other public engagement opportunities we held prior to COVID. And we're really, you know, we're looking at making sure that this engagement opportunity continues. So it's not, you know, it's not like we are hearing from you and then you don't hear anything back. There are opportunities to participate in these upcoming meetings, and you will hear more by visiting our Medicaid waiver website. So with that, our focus truly is for a waiver to advance health equity by ensuring access to coverage for all people in Oregon, creating an equity-centered system of health, encouraging smart, flexible spending, and reinvesting government savings across systems. We know these are the key pieces and that they're important based on the input we received from our community partners. And we know that without equitable access to coverage, people can't stay healthy or access the care they need. It's very clear to us at this point that the communities we work with and the communities you work with have higher rates of uninsurance. And for that reason, it's critical we continue to partner with you. Our waiver application is going to seek to reverse inequitable access with strategies to extend coverage to every person in Oregon that we can cover. Even when people do have coverage, we are hearing that their experience of the healthcare system varies widely based on their race, ethnicity, gender identity, sexual orientation, and all other social factors that make up who they are. So George gave the example of the call center volume being really high, and that poses a significant problem for people who have, you know, limited minutes on their cell phone or work Monday through Friday, these very sort of essential type jobs, and can't be on hold for long periods of time. It also presents a huge issue for people who have mental illness and may not be able to be on hold for very long as well, or people who are experiencing other symptoms. So truly our goal here is to focus our attention on policies that change this reality and ensure that our healthcare system provides an equitable and person-centered experience to everyone, every individual. We can begin to create an equity-centered system of healthcare by really looking at the consumer experience at the core. This is what we're learning in working with our community partners. So we know right now our system isn't encouraging to our community partners in terms of investments and community investments. And what we need to do is really change that approach so that we can really drive from a community-driven approach. Right now, what we're seeing is that this is really impacting our system and really in terms of health inequities. And so we want to push for further flexibility in spending really working on spending on the upstream drivers of health while making sure we have expectations that really make meaningful changes in the lives of the people that we're working with. So what we want to do is look at the larger savings that are generated. So what we can do is look at what we've done with our CCOs. For those of you who have worked with our CCOs, you know that this has been a very innovative way to coordinate care for our communities. And so we want to continue to do that, but also really look at the savings that we're accruing and take those and propose to our federal government what we want to do and how we want to reinvest those government savings to address larger or statewide problems that we know, one person can't fix. It's really, again, going to happen from a community-driven approach. So the goal is to really continue to focus on equity, and we know that we can do this by looking at different ways to fund and address larger scale barriers to health and health equity. All right, so if my slides didn't freeze, we're going to do this by ensuring access to coverage for all people in Oregon and cover as many people as we can. Right now, the problem that we want to solve is related to 6% of people who live in Oregon and don't have health insurance coverage or health coverage. And what's happening is people are sort of ping-ponging back and forth or churning, for lack of better words, on and off OHP coverage. A lot of people without health insurance are eligible for OHP or the marketplace, but aren't enrolling. So this is something we continue to hear from you. And it's very clear that communities of color are even more likely to be uninsured. So as you can see, our Latino communities, 12% are uninsured, 11% are American Indians or Alaska Natives, 8% are of our Black community, and 5% of our white community, 4% two or more races. Some of the examples we've heard from CCO 2.0, from our strategic health plan, and from some of our COVID listening sessions is that people continue to run into barriers. They are not receiving the services they need from established providers due to CCOs not contracting with that provider. Or, we continue to hear that there are concerns around access and availability of services for diverse communities. So for example, in Washington County, just about a month ago, we heard from a community partner organization, and what they said is like, we have people who speak Spanish that are really struggling to connect to therapists who speak Spanish. They can't be found, the appointments are hard to get, or people are having to experience these long wait times to get in to see a culturally appropriate therapist. And so those, this is something we've heard prior to COVID, during, and here we are. It's still a barrier that these access issues are taking place, and especially for diverse communities. We've also received comments and challenges around the contracting process between CCOs and providers. And just, OHP members really struggling with getting the choices that they're asking for. So people want choices naturally. We don't want to be told what works for us. We want the opportunity to select the type of provider we get and the type of care we get. So, we still hear of community members who want to see their doctor in person and at times, are struggling to get that option. So again, community choice is key, and these have been themes that have historically been reported. Tribal members and representatives have spoken about the need for timely access to care for their communities and the availability of various choices in healthcare as well. So this isn't just one community or another, it's really across the board, a request, a demand at this point. And members are not able to receive the care when they need it. So lack of timely authorizations. You might have a client who needs to see a specific provider that's out of network, or they're having other issues. And what happens is they have to work through their CCO for an authorization and they're experiencing delays. So I'm going to go ahead and pause before I move on to the vision, as it looks like there are a couple comments in the chat box. And then Jessica, are you able to pull up that chat box and read those for us?
Sure. Let's see, we have a few. Trying to get to the end of where people were introducing themselves and where they started bringing up thoughts and questions. One is, we would love to see Medicaid coverage extend through the first year postpartum instead of just 6 weeks. So much falls through the cracks when coverage ends so soon. And then we have a point about if children are migrating from California temporarily, about OHP coverage. Another person has pointed out that it is when people are moving within the state and need to switch CCOs or can't get on Open Card that they are seeing holdups in accessing their healthcare. I'm just going to rattle them off because I know we have quite a few and we have a little over an hour left in this presentation. And then CJ was able to put something into the chat, which is about talking more about this budget neutral mandate and what it means and how things will be funded and how to maintain transparency.
Yeah, so we are going to be talking about the budget here in just a moment. I want to actually see if Lori has any of these specific questions she'd like to answer. And there might be a few we'll need to answer in the chat box just for the sake of time. And others we'll need to circle back on.
Mm-hmm.
Sure. So on the 12-month coverage, postpartum coverage, we're looking into that. So yeah, thanks for that recommendation. And we're taking a look at that possibility now.
Thank you, Lori.
Is there any other one you'd like me to answer, Ruby?
I'm actually having a hard time looking at the chat box, but Jessica just read off a few. And let me see if I can get back to the chat box. Can migrant children who are coming from California to work during the summer, can OHP services for those? Okay, so that, Mandy, I think what Mandy's referring to, Jessica, is like if there are students here, when you say migrant children who are coming to work, I'm assuming you mean youth. Could people, as long as people intend to stay in Oregon, are living and intend to stay in Oregon, they can have OHP coverage. So Mandy, this is a great conversation for us to have offline. I can connect you with your regional outreach coordinator and we can talk through that a little bit more.
Thank you. That will be beneficial for our community that we serve.
Absolutely. So if you could make note, Jessica, for a regional outreach coordinator to connect with Mandy, that would be fantastic. Yes, and then Danielle is mentioning just the holdups with people who move from one, move around the state and have to make changes, delays in their CCO. What I would recommend, I don't know, maybe Danielle, you've tried this already, and if this is an issue, let us know. But sending a request, especially if somebody needs to get into care and they have urgent medical needs, sending a request to our community partner team. So there is a client advocacy guide for our community partners for urgent requests, and we're happy to send that your way. And what that would basically be would be an email that you would send to customer service that team is dedicated to community partner requests, specifically urgent requests that you're referring to. Okay, so it looks like some of these questions can be answered in the chat box, Jessica. And I'm just going to keep us moving, if
Ruby,
that's okay. And unless Lori, you see one you can chime in on.
yeah, I will address one because I'm sure other people are interested in this. And there's a question about implementing ideas and the mandate about budget neutrality, or that any changes need to be budget neutral. So what that means is when we apply for the 1115 waiver with the federal government, we basically say that we want to waive federal rule or federal law. And the reason that we want to do that is we believe we have a better idea about how to provide healthcare to our OHP members that is going to provide better, higher quality care, and at the same time not cost the federal government any extra dollars. So that's what budget neutral means. And so in some areas of our proposal, things will cost more, but we also anticipate having savings. And so those two things offset one another, and that's how we end up with a budget neutral proposal. And that's what that means. We also are going to be asking the federal government for some extra dollars. So that's beyond this budget neutrality, to invest in community-wide resources that will help end health inequities.
Thank you, Lori.
Yep, no problem.
I hope that was helpful. That helped me. Thank you. Okay. So the Zoom world is quite fun. I have about 3 monitors up right now. I'm trying to figure out how to get back to where I was. So to focus our vision, as I was mentioning earlier, the vision is for all people in Oregon to have health coverage, and there are no differences depending on your race or ethnicity. So essentially, what we want to see is the communities we're working with aren't going, without health coverage simply because of their race or ethnicity, is what we want to say, is what we're trying to say here. And the way we will accomplish this is to be sure we're stabilizing coverage for those at risk of becoming uninsured. Another goal is to ensure we have a flexible process that keeps people covered, and that people who are eligible get enrolled and stay enrolled. This is something we talk about quite a bit in our community partner collaborative meetings. It's like people get covered and then they lose coverage because their income ticks up a little bit, or they didn't submit a missing document. Just little changes that really cause significant snafus, for lack of better words, in someone's coverage, and then it just becomes a domino effect. So how do we achieve these goals? That is the big question. 3 steps in achieving these goals. So 1, ensure people who are newly enrolled in OHP due to the COVID-19 pandemic stay in the appropriate coverage, either Oregon Health Plan or the Marketplace, without any interruption. It's been pretty clear that OHP coverage has been stable over the course of the COVID pandemic because of the policies we have in place. This is what we're hearing from community partners, is that it's made their job easier. People don't have to stress or worry about losing their coverage for the most part. And what we've learned is that these policies have streamlined eligibility and enrollment. And it's just made it so much easier to really give people the opportunity just to self-attest their income and, not spend all this time stressing about the redetermination process. So what we want to do is to keep what has worked and build upon this foundation to be sure that people continue with this seamless coverage, especially people who were enrolled in OHP during the pandemic. In some cases, this is going to mean that people who are currently on OHP need that extra support from either a community partner or, our call center. George has mentioned people calling into the call center. And so it's going to be important that we have those trusted people available to ensure that support and seamless transition to a health plan offered on the marketplace. So there might be people who need to transition into the marketplace off of OHP, and we need to be sure we have our community partners prepared for that. And quite frankly, we really do. We are in constant communication with you through our community partner collaborative meetings. We have funded organizations we meet with every month, and plenty of opportunities to communicate back and forth. So step 2 is to ensure that people who are eligible for OHP get and stay enrolled. So we know that there have been improvements made through the One system thanks to you. We have constant check-ins with our community partners, and you've been reporting some of these issues in the One system and some of the bugs that you identify, and we take that information and we report it to all the right people to improve the system. But we know there's always room for improvement. And so we're looking at what barriers you're running into as you walk people through the One system. We're looking at anything we're making more complicated that doesn't need to be so complicated. We also know that the Oregon Health Insurance Survey is showing that 1 in 4 uninsured people in Oregon are eligible for OHP, but are not actively enrolled. So as I mentioned earlier, this continues to be an issue, and especially amongst our communities of color. So specifically among our Latino community, 1 in 3 are eligible but are not enrolled. And among non-Hispanic people who identify as a race other than white, the rates are 42%. So this is really an opportunity to do targeted outreach to those who are eligible but not yet enrolled. If we focus more of our energy on communities that are eligible but not enrolled, it'll really move us closer to eliminating these inequities we've spent a lot of time talking about. And then for those of you who have been having these very important conversations, we're also closely watching the legislative session and the coverall people bills to see how and whether there's an opportunity to build on that. So that's something that's very exciting. And the third step in achieving our goals is to adjust eligibility to preserve continuity. So as many of you know, our health coverage system is way more complicated than it needs to be. And it's very common that people get lost in navigating all that. So that we've talked a lot about the churn and the flip-flopping back and forth and how stressful that can be. And what we're going to do is aim to enhance coverage, continuity for children and families, and to expand coverage for low-income Oregonians currently not eligible for OHP. Just want to make sure we're clear on that if I haven't mentioned it enough times. Any questions about how we plan to achieve these goals together? Okay, so lots of ideas coming through the chat box I can see. And I know Jessica and Karina are keeping an eye on that to see what they can answer. And Lori, if there's something that you feel like you want to chime in on, either in the chat box or something that's good for the rest of the group to hear, feel free to jump in.
I think there's a lot of really great stuff, but I also know we have an hour to get through a good amount of content. So I wonder if having it logged and knowing we'll return to it might be good enough for right now.
Yeah, I agree. lots and lots of good content and suggestions in the chat. I just am afraid I'm not going to be able to cover them all, Ruby, but we will include them in, our summaries of the meeting and take a look closely at the suggestions.
And it's very possible that some of the suggestions you're putting in there we're going to talk about today. As I mentioned earlier, these strategies were informed, they came from our community partners. So a lot of what you'll see here today did come from some of your colleagues, and it's very possible we'll be covering it later here today. So if you're feeling like, okay, Ruby is just telling me things, but I want to talk too, we want to just make sure we come to you today to say, here's what we've heard from you. That information did not get lost. Hours and hours of time has gone into community partners voicing and amplifying some of the issues they're hearing. And so we want to be sure we come to you with the strategies, and we want to know if we're still on point or something needs to change. So our first strategy, as Lori mentioned earlier, is the 5-year continuous eligibility for children. And so for kids, this means children will be able to keep their OHP. They get to see their health providers longer, which results in better health outcomes. And this is good news, not only for children, but for parents and caregivers who are constantly stressing about experiencing those gaps in coverage. So less worry about redeterminations when there's a small change in income. And the second strategy is related to self-attestation of income. So many of you have already been experiencing this during COVID. You know exactly how to do this work when you have communities who are reporting their income. So they'll be able to basically just share with you what their income is. And then that gives you time to gather any paperwork needed. So there's that flexibility of time. And whenever possible, we will look at existing resources or sources like recent qualifications for SNAP, for food stamp benefits, to reduce any paperwork. So hopefully that will reduce some of the barriers. Our third strategy is to adopt policies that keep families covered together as income changes. So for members who are part of a family, children would be covered up to a higher income level, and the adult members could be too. This would mean that members don't need to figure out different insurance benefits or navigate different networks for different members of the same family. Our fourth strategy would be to expand coverage for low-income Oregonians who are currently not eligible due to immigration status. So if you're working with communities right now, and this was something we heard in the first meeting, is a lot of times I sit down, I walk families through the application process, the children are eligible, but the parents are not. So this would fill that gap. This would mean that you don't have to be putting different family members, hopefully in different networks, or separating people, and then it causes more confusion. And then strategy 5, seek more funding for outreach and support to enroll eligible people. So investments would be made in outreach and engagement. We know that this is something our community partners have asked for. Previously, we've had community outreach funding opportunities, and we continue to hear that there is not enough funding going into outreach and enrollment, and it just makes it more difficult to get the word out in a culturally appropriate way so that people enroll in coverage. So what we're looking at is, to maximize available federal dollars to support increased enrollment among people who are eligible. So notice we have our little icons here. And what this means is that we have a poll. And so keep an eye out for the poll, as I'm going to go ahead and get back into polls here. Just bear with me. Okay, so you should be able to see a few questions here. What we want to know is, are we on track with these strategies? Do you think they would work, or do you have any concerns over any of these strategies? Do you foresee any unintended consequences, or something that maybe we think this is a good idea, but it could cause more harm than good? And so you should be able to see the poll. And Jessica, if you could, oh, yeah, it looks like people are answering questions. So you must be able to see, there's the thumbs up. Thank you. All right, so if you ran to take a quick restroom break, we are opening up our poll, our survey question, and we want to hear from you. So we have 5 strategies to provide the 5-year continuous eligibility for children: 2, allow applicants to self-attest to their income; 3, seek more funding for outreach and support to enroll eligible people; 4, adopt policies that keep families covered together as income changes; and 5, expand coverage for low-income Oregonians currently not eligible due to immigration status. So it looks like half of you have voted. We do need to continue to move, so I'm going to go ahead and wrap this up here in like 5 seconds. So let us know if we are on track or off track. It's very interesting. It looks like the self-attestation to income has an interesting mixed bag of results. So for those of you, it looks like 15 of you so far have said, no, I see issues with self-attestation to income. Feel free to include that in the chat box. And there's also a mixed bag with adopting policies that keep families covered together as income changes. So if you are concerned about that strategy, please let us know in the chat box. All right, I'm going to hit end here and share results with you so you can see where we landed. So as you can see, it looks like we're on track for most of the strategies. There was an interesting higher uptick on strategy, let's see, where'd it go? Strategy 2 and strategy 4. It's very interesting. All right, well, thank you so much for your input. And I'm gonna go ahead and pass it on to Karina or Jessica.
I'm ready.
You're ready, thank you.
All right. So next we're going to talk about creating an equity-centered system of health. Next slide, please. So the specific problem that we want to solve is the fact that the health system is complicated and it's hard to navigate through times of transition. And for some examples of transitions, that's incarceration, perhaps a destabilizing life event, such as going in and out of foster care, something that might have mental or behavioral health complications, discharge from an institutional setting without that stable housing available, and someone who maybe is experiencing houselessness or housing insecurity. Next slide. Our vision is that people have access to the services and supports they need to be healthy and well, especially through times of transition. I'll move right ahead to goals. So our goals are to improve coordination and supports for members who are making those transitions, maybe across systems or within their lives, including flexibility around eligibility and their coverage. Also, to improve access to culturally and linguistically appropriate services, and to prioritize people who are experiencing inequities and the groups of people who are most at risk of those inequities. I'm trying to toe the line between being fast and clear. So let me know if I'm not quite getting there. A few of the pathways that we've identified are, first off, to look at what are those most disruptive transitions, where can we move the dial, and where is that opportunity to make a difference. Oh, and that, let's see, I think one more. There we go. And that, oh, okay, yeah, slide 26, perfect. And that includes creating new packages of services and supports for different transitions, because transitions aren't all exactly the same and people's experiences and their needs will differ. Across the board, improving the behavioral health system as it exists here in the state, and make sure that not only clinical providers, but non-clinical ones also have the resources they need to be good partners in care. And then another pathway here is getting better at knowing when people are going through or expecting transitions so that we can make sure they get the care that they need when that transition happens and as quickly as possible. Next slide, please. So we have a few strategies that align with these goals. The first one is to potentially waive the normal requirements to cover some things that are not usually considered medical care. So OHP members who experience certain situations or transition in and out of different systems, they could see enhanced supports and coordination during that time of transition. And we would need to predefine those supports, and that would include both expanded medical supports, for instance, accessing traditional healthcare workers, as well as things that substantially support a person's health but aren't typically considered medical care. Perhaps that means helping people obtain or keep their housing or other things that are outside of that, specifically medical model, or I should say traditionally medical model. Next slide, please. Strategy number 2 is to look into early Medicaid enrollment and assessment for people who are in prison or jail or at the Oregon State Hospital. So we know that when OHP members are going into or coming out of jail or prison or certain healthcare facilities like Oregon State Hospital, there are delays that we could find ways to help them keep their OHP coverage or get back onto that OHP after release more timely than we currently are able to. Next strategy, please. Strategy number 3 is providing OHP to every child experiencing a behavioral health condition. And understanding that meeting children's behavioral health needs is a really important part of caring for their overall health. When behavioral health concerns are addressed, children can experience better health outcomes overall. And so that is why we're pursuing this strategy. Strategy number 4 is to leverage federal funds to support a unified statewide behavioral health crisis system. So this relates to some federal requirements that states stand up a robust crisis system. You might hear it called 988, the numbers that you could call in this system. This would be the call center, and that would be a front door for people experiencing any mental health or substance use crisis, and could match people to immediate and appropriate care and divert them from emergency department and the criminal justice system. This doesn't directly impact OHP members per se, but if we can achieve this, then there's a potential for increased investment and an urgency to establish that statewide mobile crisis system. Now, strategy 5 is the use of peer-based services and community health workers. So what that means is allowing recovery peers to be paid for providing services outside of a traditional treatment plan, and or to utilize in lieu of services to allow services outside of that traditional medical model to address those social needs of people, such as housing supports. So this strategy provides additional ways to engage people in care and offers increased support during early recovery that can lead to better outcomes. Now, strategy 6 is a reserved capacity for children in child welfare. And what that means is that we know that children in child welfare custody in Oregon have challenges getting the right care at the right time and for the right duration, and specifically as it relates to psychiatric residential treatment services. So this strategy would support reserving capacity for children in the custody of child welfare so they could get this level of care when they need it. And we also know that children in child welfare are disproportionately from communities of color and from families that are experiencing substance use disorder and impacted by poverty. All right, next, thank you. Just a quick call out to some tribal specific strategies that are at play as well, which include definitions and additional coverage for tribal specific practices, looking into ways to reduce the administrative burden, specifically with billing and reimbursement, and continuing existing programs that are working well for tribes and tribal members. And I zoomed through that so that we would have time to talk about if these 6 strategies sound like the right strategies, and we're going to have a very similar experience to the poll for the last set of strategies. And so we're asking, are these 6 strategies the right ones? Let us know if we're on track. And you can also use the chat box to add in anything beyond the what the poll will be able to support.
Thank you for adding that, Jessica. We summarized this one just for the interest of time. So if there's one that you don't agree with, or you feel like that's actually going to have unintended consequences, or maybe we need to adjust something, please do include that in the chat box. And it looks like we have 40% of people. Ooh, you are all moving quick this time. 45% people have voted.
I'm catching up on the chat box because I can't see it while I'm speaking.
Yeah, so at least 10 people have identified that we're almost there and not quite. So for those, if you are someone that marked almost, let us know what might be off. And if you're the 1 or 2 people who said no, let us know why. What are we missing? Okay, I'm going to end this here in just like a few more seconds. All right, so if you're clicking your button, you're going to want to wrap up because I'm going to go ahead and hit end polling. Okay, so 67% yes, these are the right strategies. 3% said no, and 31% of you said almost. So we'd love to hear from you and know a little bit more about what your thoughts are if you feel like something's missing and we're not on track.
Ruby, I'm getting some, I don't know if it's just me, I'm getting some, I don't know, fuzzy computery sounds with your voice.
Yeah, I hear that too.
Okay, is that any better?
Oh, that was much better.
All right, well, I'm going to turn it back to you.
Thank you, Ruby. And just as a reminder, any additional information you want to, or feedback you want to give us on this specific set of strategies, please feel free to use the chat box. And we can move on to our next section, which is encouraging smart, flexible spending. Now, the problem to solve here is a little more complex than the last one. I'm going to start by reading through this very quickly. Many people find it difficult to use health-related services. You may also hear that called flex funds that help them access food and other non-medical services. And we know that these things keep people healthy. And we know that CCOs have the opportunity to use them. But we also know that people are facing this statewide additional housing crisis. There are climate emergencies. There are inequities caused by structural racism. It's harder with all of these various social determinants and other factors to stay healthy. Access to healthy food is something that may be not available due to lack of ownership and poverty. A majority of clients do not have their basic needs met: housing, food, employment, benefits, transportation. And on top of that, there's also a need for childcare and paid childcare to allow low-income families to work. So in general, there are all of these complicating factors that, as I was alluding to earlier, are outside of that traditional medical model, but can really make a big impact on people's health. There are gaps in behavioral health spending, especially when it comes to children with complex needs and people experiencing health inequities. And this ties in pretty closely to what we just talked about as well. And many communities want more say in how CCOs decide to invest. And so there's an idea to protect and focus on global budgeting, to improve reimbursement for behavioral health services and services that support those social determinants of health. Incentives that are targeted not only about clinical settings, but those system supports and moving more upstream and focusing on prevention. And see more incentive payments go to the community advisory councils, which is something that I think was brought up at the very beginning of our conversation today, that we could have the CACs carry out projects in communities and focusing on value-based payments and seeing how that payment structure to see if it is the right solution and in what ways we can leverage it. I'm gonna move on to vision next. And our vision is that the way that Oregon pays CCOs is predictable while being flexible, and that it creates an incentive to address the person's medical and also social needs, invest in preventive care, reduce costs and programs, reduce costs, and programs to improve community health. Sorry, my reading is failing this afternoon. And to really be accountable to the community to eliminate health inequities in Oregon. Next slide, please. So we have 4 goals here, which is people, especially those experiencing health inequities, get the care and supports they need to stay healthy, including services to address health-related social needs. Another goal is that CCOs focus spending on health equity, prevention, care coordination, and quality, because these are smart investments that will help to maintain that sustainable cost growth. And that communities have significantly more say in the spending decisions that impact them, especially when it comes to those health inequities. And finally, that Oregon creates savings that can address health inequities in the state by maintaining a sustainable rate of growth in the CCO program itself. And this is where we get a little bit weedy, so I will do my best, but I also know we are a little limited on time. So if there are any parts of this that you all want to hear more about or hear more explanation, please let me know. The pathways. So we want to use innovative rate methods to set global budgets that encourage efficiency and upstream investment. That's the idea that if we have flexibility to spend money where it's going to make the most impact before people get sick, before things get really costly and they have really intensive health needs, then that is a pathway forward. And to helping CCOs be accountable to the community and to the correct amount of incentives and types of incentives to really focus on this. Hold the CCO program to a sustainable cost growth target in line with statewide efforts to contain healthcare costs. And that cost growth The cost growth target is that we know that healthcare spending goes up, but if we limit the amount it goes up, then we have that extra money that we didn't spend to use elsewhere, and we'll talk a little bit more about that. We also have this plan to increase CCO accountability to delivering care and supports that members need. And part of that is budget flexibility and that sustainable growth target. And those two things alone don't ensure that CCOs will use that flexibility that they get to best serve members and communities. So Oregon will continue to hold CCOs accountable to providing those contractually required benefits and meeting basic quality and access targets, even while pushing to use this flexibility to shift resources upstream and target those health inequities wherever possible. We also have enhancing the community voice in the CCO model to ensure that community priorities and needs are driving spending decisions. And part of that is revamping Oregon's metrics program so that equity is the primary organizing principle. I think I'm going to move on. I have a whole extra page of notes, but we can return to that if we need to. So strategies. Strategy 1 is a flexible, sustainable global budget that protects member access and targets health inequities. So for OHP members, I can go back. Oh, for OHP members, this means more accesses to services that address their health-related social needs. For members with higher healthcare needs, this means better care coordination, including access to additional benefits when transitioning to and from institutions such as jails and prisons. So you're starting to see how all these are really connected to one another. We can move on. Thanks. Okay, we have an opportunity to hear from you now, which is what can we do to improve on healthcare coordination for members with higher healthcare needs? And please use the chat box to put in some information on what you're seeing and opportunities you're seeing. And I'm seeing that you all have been really active in the chat box, which is awesome. I want to take a quick check with Ruby and Lori to see if there's anything that you would want to add or any specific questions you want to make sure we address or comments.
Hey, Jessica, I'm just sort of looking through the chat box and reinforcing some of the questions and input that we're getting from community partners. So if there's something that I can just reinforce, like, hey, yes, we hear you. This is coming up constantly. I'm doing that in the chat box. And just want to flag that there's, there are some suggestions here that maybe aren't related to the waiver. However, they're still very critical. And they are things that we can take to our ODHS partners. For example, a dedicated line for community partners to troubleshoot enrollment issues with clients. That was something that came up in the chat box.
I see that Lori has also been chiming in response in the chat box. I thought I saw a hand raised for a second. Is there someone who'd like to speak?
Yeah, Jessica, this is George.
Hello, George.
I want to make sure I heard right. The CAC, the CCOs, we're going to be responsible in the method payment.
I believe so. The idea, I'm trying to get back to my notes on that specific item, is that giving the CACs perhaps incentive payments to carry out projects in communities. And that is one of the potential ways in which we're looking to solve some of the problems built into this particular topic. So it would not be being in charge of value-based payments or anything like that, but it would be potentially having funding to carry out projects in communities to address health inequities.
Okay, because I want to make sure I heard right, because because the board of directors are already doing that. I was wondering if, I want to make sure that the CACs aren't having to decide that base payment to providers. I want to make sure that that was clear, that we're not doing that.
I'm fairly certain, yeah, that's not, and I'm sorry if I gave that impression. I think I listed a bunch of stuff in quick succession and they all ended up together, so I'm sorry for that.
Okay.
And then Harumi, I see your hand raised.
Yeah, thank you. Can you hear me okay? Perfect.
Yes.
I was just hoping we could get like an example for this particular question. I wasn't sure if it was the social aspect that you meant or what. Yeah, if you could get some kind of example for what do you mean by members with higher healthcare needs here?
Yes, Ruby. I think your box lit up. Maybe not.
This is Lori, I'll add to that. So healthcare, in terms of coordination, this would be members who have more healthcare needs than kind of your average person. So that beyond what could be met if they go to their primary care doctor. So for example, somebody with special needs, somebody with a lot of social needs. So, you know, for example, a member who's at risk of becoming homeless, they may have more needs, also healthcare needs. So if they have a chronic condition like diabetes, so those kinds of members that need more than what can be addressed at their regular primary care doctor's office visit.
Thank you so much, Lori. I'm seeing opportunities for traditional health workers to cross-train to better serve complex medical cases, making sure that those services can be billed. Some specifics about CCO switches for higher needs folks and being aware that they have a harder time with those CCO switches and planning for those transitions. I think that relates to a couple of the different priorities we talked about. Thank you, Sean. And then a question about THW's traditional health workers. You may also hear community health workers. It's a variety of work that is not specifically medical that really does address those. Social determinants of health often meets people in communities, not necessarily in a medical setting as well. I think at this point, I'm going to let people continue to put really good questions, comments, and information into the chat, and perhaps we move forward.
Yeah, I think that's a good idea, Jessica, since we're running a little short on time.
All right, I think we're ready for the next slide. And is that?
Yep, that's
Okay.
me. Thank you. So next is strategy 2, the shift power to community to direct community investments. So while CCOs have leveraged flexibility in their budgets to direct increased spending toward health-related social services, spending remains low compared with medical care. Additionally, the fact that health inequities persist suggests the need for not only increasing community investments in community health partnerships, but ultimately shifting the power balance between the CCOs and the community. And this work will require not only building a stronger model of community decision-making and direction, it will require building on ideas that have come directly from community and collaborating to build a new model directly with community. we could go to the next slide. Perfect. So another question here, how do we shift power to community to direct community investments? And if you could all use the chat box to share more of those ideas, please.
Hey, Karina, can you hear me okay?
I can hear you now.
Fantastic. So as people are answering this question, we just want you to think about how we partner up with you. We want to understand how we accomplish this together and really how you see this happening. So a lot of times, you know, what we hear from community partners is that, you know, they're tired of hearing from OHA on what we need to do, and community partners want to be driving this work. So this is really for us to partner with you and say to you, how do you see this looking? What is your vision? And really make sure that our community partners are designing this sort of direction that we're going in. Thank you.
I see a comment here. It's challenging to get OHP members to participate in CACs, possibly a town hall or online survey link for feedback. Folks who should have their voices heard may not always have the time or capacity to go to a meeting to discuss CCO investment. Having simple surveys with desires and friendly lower literacy language would be good.
Thank you. So Karina, I imagine that this is sort of a loaded question, right? And people will probably need some time to process this.
Yeah, I think it'd be a good idea if folks can continue to put in their ideas and share with us, and we can probably, I think, keep going forward. I don't think there's another one of these time to hear from you questions for a couple slides. Perfect, thanks, Ruby. So our next section is about reinvesting savings in communities. Next slide, please. So reinvesting savings in communities, social issues that cause health inequities often extend beyond the scope of the healthcare system. So our waiver renewal will seek to reinvest savings to combat health inequities at the community level. So if we contain costs and prove to the federal government that it has saved money, we're hopeful that they'd allow us to redirect those savings into investments that address inequities. Next slide, please. So then we have 3 goals, which are to reinvest savings generated through health reform toward communities to improve the social, economic, and physical environment. The second, to focus on large-scale investments that are targeted towards eliminating health inequities. And the third, partner with community leaders to identify and operationalize strategies to eliminate health inequities. And we'll go on to the next slide, please.
And then Karina, I just wanted to remind you, we do have an interpreter on the line for our Spanish-speaking community partners. And he's just reminding us that They're just reminding us that we should read the questions a little slower.
Okay. So the next question, pathway, how do we achieve these goals? Step 0 is to implement the Sustainable Healthcare Cost Growth Target Program. Step 1 is to keep the savings achieved through slowing the rate of healthcare cost growth for Medicaid and Medicare Advantage. And step 2, invest those dollars in innovative models that extend across populations experiencing inequities. Next slide, please, Ruby. And the first strategy is to establish a way to calculate projected savings to Medicaid and other federal programs, and for CMS to give Oregon back a portion of those savings to reinvest in health equity initiatives. OHP members should not see any negative impacts to their care as a result of this agreement and methodology for calculating projected savings. And the second strategy is to reinvest savings by piloting new community identified health equity zones. So examples include enhancing green space and making improvements in the built environment, increasing access to social and mental health supports, expanding availability of affordable childcare and housing, and then depending on a community's need, they may focus interventions on a specific population, such as children. And our third strategy, to reinvest savings in statewide equity priorities. And those examples are to enhance the healthcare workforce to provide culturally responsive care. All right, so our next time to hear from you section. What are some ideas you like on how we could work together to enhance the healthcare workforce to provide culturally responsive care? And then if you could please use the chat box to share your ideas.
Karina, while we're waiting, it looks like, just so you all know, there's a new interpreter that is going to take over for those of you who are on the Spanish channel. And so if you heard 2 Spanish interpreters speaking and it caused confusion, just know that Oscar will be taking over and you should only hear 1 interpreter at this time, hopefully. Thank you, Claudia. Claudia says the interpreter is on. Things are working great. So thank you for those of you who are just silent processing right now on the question Karina just shared with the group.
And I think we can sit here for another minute to have folks share, but I think after that, we'll continue to move forward, Ruby, so that we have enough time to wrap up.
Yes. And if people think of ideas after our meeting today, we will be sharing an email address. You can follow up there. There's a lot of workforce ideas coming through, which is really fascinating to me. Thank you, Danielle. All right, Karina, do you want to get us moving along? And
Yeah.
then partners can keep adding their ideas.
Yeah, let's go to the next section. So this is our last section for today, the process and timelines. So our question here is, what are concept papers and what purpose do they serve? So there are discussion draft papers that lay out the vision, goals, steps, and possible policy strategies to share with stakeholders, community partners, OHP members, and CMS. So the main purpose of the waiver concept papers is to make each waiver concept more easily understandable to state policymakers and the general public, and they allow for discussion, feedback, and input. So this isn't the stage for operational details. We're really trying to carefully balance how to invest the right amount of time here. So now that we have a clear vision and exciting ideas, against overburdening anyone with implementation planning for CMS, has indicated which of these ideas are promising enough to discuss. So from our discussion with CMS on the individual concept papers and that back and forth, eventually we will land on a proposal that we believe they can support in our application to them. And these concept papers build on the strong foundation of the CCO model with some shifts based on what we've learned is or is not working and what innovative future awaits. And I think the next slide, I pass it back to you, Ruby.
Thank you, Karina. I'm going to step away from the chat box. So if you could keep an eye on that for me, that would be great. I just want to go ahead and talk through our timeline. In June, we released the draft concept papers for public comment. We did release the draft concept papers in Spanish along with other languages in late July. So you should have received those again in your inbox for those of you who have requested those in Spanish this morning. And they are out there. If you need them in any other languages, you can definitely find them on the Medicaid Waiver website. You can email us at community.outreach, or you can send an email to me. You should have my contact information and all the invitations you've received for this meeting. And just know that this is the opportunity to provide feedback on these keyword draft concept papers. Okay, so now you can see me. It was in late June that we held our waiver work session number 2, and there was a lot of feedback from that session. And it's July 6th already, so we've, as Lori mentioned, had our Oregon Health Policy Board meeting earlier today to discuss these second drafts, and we've gathered with you today to discuss our strategies and our second draft. So the process really is at this point where we're just waiting to hear from our community partners and working on this next draft so we can submit this to CMS. I would just definitely encourage you, if you can make time this week, to look through the policy draft concept papers and share any ideas you have on our strategies. We want to hear from you. You've said it yourself, nothing with us, nothing about us without us. So keep sending all of your input and ideas, and don't hesitate to let us know if there's something that could have unintended consequences. So how to stay involved, you can visit our Medicaid waiver website mentioned a few times. You can submit your comments and questions related to the waiver here at this email address, the 115waiver.renewal@dhsoha.state.or.us. I know I said that very fast, so I'll say it again. The email address is 1115waiver.renewal@dhsoha.state.or.us. If you received this meeting invitation from a friend or a coworker, we can add you to our email list. I see there's a typo here in my slide, but just be sure to email community.outreach@dhsoha.state.or.us, and we can get you on that email invitation list. Very important, partner with your regional health equity coalitions. These regional health equity coalitions across Oregon have been discussing Oregon's Medicaid waiver, and they want to partner with you. They want to hear from you. So please do click on the link to find a regional health equity coalition near you. After this meeting, we will be following up with a list of resources so that you know exactly where to raise community voice, not only for waiver work, but for other type of health system input. So know that that is coming your way. And most of all, thank you for your time today. I know a lot of you have multiple competing projects, and you're out there on the front lines responding to some of the COVID work, community resources, vaccine events. I know you are all very busy. Karina, Jessica, and I talk about all the wonderful work our community partners do day in and day out. And there's just no way that the world would turn without you. So thank you so much for taking time out of your day to join us here. And it looks like we have just a few more minutes. So we'll be here for the next 5 minutes, keeping an eye on the chat box. Or if you want to unmute yourself and add anything, there's still time.
Ruby, this is George.
Hi, George.
Would like to suggest, because of this Medicaid waiver stuff and OHA and O and other insurance that having a hard time pronouncing, people from other states like Arizona, Montana, Idaho, and all that are coming into Oregon would like to suggest OHA to, or the CCOs at least, when they're signing up for services through DHS, which is the Oregon Health and Human Services, on this one plan, for them to be sent a application to people like with a disability from other states, so it could be already into the system before they move into Oregon.
Okay, so it sounds like what you're suggesting is if there is a person who lives in California and is planning to move to Oregon, it would be helpful for them to have an opportunity to start their application process before they get here so that they don't have any sort of gaps in coverage.
Correct. Whether it's through the DHS, OHA, but people that have, especially with the disability that is moving from another state and wants to move into Oregon permanently.
Yeah, thank you for that feedback, George. We can definitely look into that and see if that's something that we could do.
It would make their process a lot easier before they get into Oregon.
Yeah, I hear you. I know that that clients have to wait until their benefits turn off in other states, and they run into those barriers is what I've heard from community partners. So I appreciate you bringing that up.
Okay. And I would wonder if I can have the PowerPoint sent to me to my address or email.
Absolutely. We will definitely follow up with the entire group. So you should be getting these slides within the next 24 hours. And we will also follow up with a recording in case somebody on your team missed the meeting. They'll be able to participate at their convenience.
Thanks, all of you did really good work. So
Thank you, George. Really appreciate it.
thanks.
Mandy made a note. It says same thing with migrant workers. Mandy, are you referring to when people are moving here? It's just they have to wait to start that coverage. It would, and I think what you might be referring to is related to what George mentioned, is people moving for work, right? That just having to wait until they live here creates those extra barriers and having to put off coverage. And Sean, who's been around and doing this work for a very, very long time, is reinforcing what you're saying here, is that it's just, there's a lot of problems with other states and how to move forward when people come here and that transition time. Wow, he goes as far as saying that just preparing for people's arrival would help avert homelessness in some cases. And then Sean used an acronym, long-term care cases. Is that what you mean, LTC?
Yeah, that was, hopefully you can hear me. That case I'm speaking of was a person who had moved here from Nevada into a hotel. We were trying to get a long-term care case approved so she could get into an assisted living facility. Her benefits, and it took us about 6 hours on the phone with them to get those to close before we could proceed with the long-term care case here, which eventually was how we got her into housing with much assistance from the local APD caseworker. But just if we could begin that before she had arrived in Oregon, that would have saved her a few days in the homeless shelter. And just, I'm sure there's more people in those situations that are having those difficulties.
And Sean, correct me if I'm wrong, but what I've heard from community partners is that they call into the call center and the benefits have to be turned off in another state in order for those benefits to turn on in Oregon. Is that what people are experiencing when they come here? That's
what I ran into. I think it might be specific to long-term care case requests as opposed to all the non-metro medical ones, but it seemed to be that they could not proceed with the application at all until the SNAP case was closed in Nevada, which we took a few days to get through to them.
And if the client is trying to get through their call center and they're on hold, it creates another barrier, right? If they're calling, is that what is still happening?
Person had pretty irregular access to phones, and so I ended up doing it with them, and so we could have access to our phones and use that. We eventually got through, but it's just a difficulty because we don't have any special ability to talk to other states or anything like that. So, and we'll have to learn the processes to contact their other program at the same time they are.
Right. Well, I'm very grateful this person had a community partner to walk alongside this process with them. And I just appreciate all the work our community partners are doing to assist people with navigating the coverage. So we will definitely make note of the barriers to people, not only when they're moving within the state, but moving into Oregon and turning off their benefits and accessing benefits when they arrive here. Thank you so much for bringing that up. All right, everyone. It is time, and I'm sure some of you are getting hungry or have kiddos to pick up and other family matters. So thank you so much for joining us again today. And you will be hearing from us. Take care, stay in touch, and we're looking forward to seeing you at our next community partner Medicaid waiver meeting. Have a great day.
Thank you, Ruby, and thank you all.